Good morning and welcome to the Quality Network for Older Adult Mental Health Services first webinar. My name is Fatima and I'm the Deputy Programme Manager on the network, and behind the scenes we have Rob Lowe and Connor Booker helping to produce this session. And I'm absolutely delighted to introduce to you all Dr Frances Duffy, who will be talking to us about supporting carers and care staff to understand the changes in behaviour in people with dementia during COVID-19. But before we start, here are a couple of just a few housekeeping notes. If my slide allows me to move. Bear with us. So the webinar is a live event and you will be on mute unless you are a designated speaker. The webinar will be recorded and uploaded to our Knowledge Hub, which is our online resource centre. Currently it's only available to our QNOAMHS members, and I'll tell you a bit about how you can become a member shortly. But as this is a public event, it will be made available on our website, and we will also be sharing the links in an email after the session. There's also a chat function which you can use to ask questions. If there is a question that is similar to your question, rather than asking it again, we appreciate if you vote for it. That way, at the end, we can ask the most popular questions to Frances. If you can't access the chat box, please email us and we'll do our very best to pick up the questions there. So, as you know, this is a free event accessible to our non-members and the general public in this unprecedented time. However, for those of you who haven't engaged with us previously, we are a membership network that works with older adult inpatient services to improve the quality of older adult mental health services. And we do this by working with our staff, service users, carers in a comprehensive process of both self and peer review for the purpose of quality improvement and accreditation. So like this webinar, we also have a range of resources such as access to best practice bank. We put on regular knowledge sharing events such as special interest days, annual forums, peer review training, all to, I guess, help our members to immerse themselves in driving improvement in the services and getting access to the right support and knowledge to help them to do this. We would highly encourage all trust as well as independent providers that are providing inpatient mental health service to older adults to become a member of our network. Our vision is for each and every older adult receiving care in inpatient mental health service to have access to the high quality care for themselves and for their families, and for staff working on these wards to work in an environment that is enabling and that supports and provides the right training and support to them. And we can only do this if we all come together and work hard to improve and drive improvement within these services. So this year has been quite an interesting year for us, because this year we launched our 5th edition of our quality standards, and our standards are based on national best practice and guidelines. They are also developed by our member services, working with carers, patients and range of stakeholders to provide a rounded vision of what high quality services look like. To find out more about our membership and how to join, please do email us. You can also visit our website, and we'll also be providing instructions to attendees on how, after this webinar, they can sign up to our network. So without further ado, please let me hand you over to our speaker, Dr. Frances Duffy. Do bear with us while we change slides. This is the first webinar. There might be one or two technical glitches, but please do bear with us.
So good morning, everybody. It's quite difficult that I can't see you, but you can see me in the slides. So first of all, I'd like to say thanks to the Quality Network for Older Adults Mental Health Services for inviting me to deliver this webinar today. So I'm going to talk about understanding and responding to behaviour and dementia during COVID-19. I'm a consultant clinical psychologist working in the Northern Health and Social Care Trust, and I work in dementia service, which includes memory service, diagnosis of dementia, and also post-diagnostic support services for people following a diagnosis of dementia. The talk today is going to be based on the principles of clear dementia care, which is a model that we developed within our dementia home support team in the Northern Trust. I'm not going to go into the details of clear dementia care, but if people are interested, then they can look at the Trust website for more information. But I think it's important to highlight that when we're talking about behaviour and behaviour of a person with dementia or behaviour with anyone, it's important to look at the whole person. We can't just focus on what the behaviour is, because we know that our behaviour is driven by a number of different factors. And there are 5 domains that we see as important, and that's our cognition. So those are our thinking skills, our language skills, our ability to understand and problem solve. And also our behaviour is determined by our life story and our personality. So our previous experiences in life determine how we behave and engage with the world at present. But also how we're feeling is really important. So our emotional well-being, if we're anxious, if our mood's low, and if we're physically well or unwell, will determine how we behave. And also the activity and the environment that we're in. So if we're in an environment that is it's quiet and it's a good environment for us, then our behaviour will be different than if we're in a very kind of noisy environment. But also, more importantly, perhaps, it's the relationships that we have with other people and those around us. So those are our friends, our family, etc. So all of these factors come together and determine how we behave and how we respond to any given situation. So if we think about then behaviour in general, well, all behaviour really is a form of communication, and that behaviour is driven by need. So it's really important to understand that none of our behaviour is random. So for example, if I'm sitting in my settee of an evening and I get up from the settee, that's not just a random act. I've maybe got up because, you know, I want to get a drink of water, I may want to go for a walk, I may need a change of scenery, or I may have somewhere to go. So it's not random. When we behave in any way, it's usually because we plan to do something. But the difference between someone like myself and someone with dementia is that I can explain my behaviour. So if I get up from my seat, I can say to the other people in the room, oh, I'm just going to get a drink, or I'm just going for a walk, and I can tell them what I'm going to do. But a person with dementia may not be able to do that because they may not have the language or communication skills in order to tell us what it is they want to do and what it is that they need. So what that means is it places the burden on us, or the onus on us really. It's not a burden necessarily, but it's up to us to try and interpret what the person wants and what their needs are and help them to meet those needs. So this is the way in which we interpret behaviour. But if we think about the impact of COVID-19, well, that's really changed the whole playing field for us, but also with people with dementia. But when we think about the behaviour of a person with dementia in the context of COVID-19, we have to look at the whole situation, because we have to look at the impact on the person with dementia. We have to look at the impact on their families and their carers, but also the staff who care and support for them. And all of these factors and all of these people interact, and they affect how the person with dementia feels and how they behaves. So when we look at the behaviour of the person with dementia, we also have to look at all of those that are around them and how they may be impacted on that behaviour. So I'll give you some examples of what that might be. So if we think about the person with dementia, their life now is probably very different than it was 6 weeks ago, before the situation of lockdown and before the COVID-19 really took effect. There's been a real change in routine in terms of what the person does, so their day's probably very different. There's also been that significant loss of family and friends visiting. So for people who are in care homes, for people who are in inpatient settings, or even people who are living in their own homes, family and friends just aren't visiting because of social distancing. And that's a significant loss to people. It's a loss to us because we're in a situation where we're all social distancing. But for us, we can rationalise that. We can understand why we're socially distancing. But for a person with dementia, their family and friends may have just disappeared and they may not understand why they've disappeared. So we will need to remind them frequently about why friends and family aren't able to visit. But that's a significant loss, and that's a loss on top of all of the other losses that a person with dementia has experienced throughout their lives. There's also the loss of activity, because for many people, they may have gone out to do activities. They may have had activities within the environment they're in, such as in a care home or in an inpatient setting. And perhaps because of physical distancing at the moment, it may be that group activities are no longer offered. It may be also because of risks of infection. Some of the equipment that was used in activities, or the activities that people had access to, they may no longer have access to these activities. And that's a significant loss in people's lives. We find that ourselves with maybe activities that we would have normally, engage with in the evenings, or maybe no longer to do those anymore if they're outside of the home. But also for the person with dementia, there's a change in staff. Because what we know is that some of the care staff who support people with dementia, they themselves may have been infected with COVID-19, so they may no longer be offering support. So there may be new staff that are working, there may be agency staff, and that can be very unsettling because the person gets to know the people that work with them, and if those staff are no longer available, the person will wonder what's happened. And they may not quite understand why the members of staff that I really get on with, why are they no longer available to me? But the other thing as well is that even the staff that are present, they may no longer be as available to the person as they were before. So for example, the staff may be busier, so they may have less time to spend with the person. So staff who could sit down and spend 10 minutes talking to somebody may no longer have those 10 minutes if there are staff shortages. And there also may be a change in the way the staff respond to the person, because when we're busier and we don't have time, the way that we respond and engage is different. But the important thing to understand is the person with dementia may not understand why all of this is happening. So the staff know why they have to behave in that way, but the person with dementia may not understand. If we also think, though, about the response of the care staff. So care staff aren't robots. Care staff come into work and they have their own lives. And we're all worried about COVID-19 at the moment. We're worried about the impact on our own health, and we're worried about the impact on the health of our families. So care staff are coming into work with this worry. The other burden that care staff are experiencing at the moment is the impact or the availability of PPE. So, for example, there was on the news headlines, there's been a lot of press in terms of whether or not appropriate PPE is available. So that can cause increased anxiety for staff in terms of whether they feel safe within the environment. Also, staff will have the experience of less staff around them. So it might mean that they're busier, and this can put them under increased pressure in work if they don't have the colleagues there to support them. The other significant factor, though, that staff have been reporting recently is that there has to be a change in the way that the care is delivered. So that staff nowadays aren't delivering care in the way that they would have delivered it before. And sometimes staff feel that the care that they're able to offer at the moment is not ideal and is not what would be predicted. And that can have a real negative impact on staff mood when they feel as if perhaps they haven't cared for the person. But the anxiety, perhaps feeling overwhelmed at times, and stress can impact on the person with dementia, because fear and anxiety spreads. It's kind of contagious. So the person with dementia will pick up on the emotions of staff, and if the staff are feeling a bit anxious, overwhelmed or stressed, then the person with dementia is equally likely to feel more anxious, overwhelmed and stressed. So we need to see the behaviour of the person with dementia in the context of the staff around them. So what's really important when we start to think about behaviour is to think about perspective. So the person with dementia may not have the ability to see our perspective because of their challenges they have in terms of their thinking and reasoning skills. They may only see their perspective. But as staff and individuals, families, carers, etc., we can try to see the perspective of the person with dementia. And if we try to do this, then we can offer support in a way that reduces their distress and reduces potential anxiety. So our role really is to try and see the world through the lens of the person with dementia. But one of the important factors that we need to consider before we even address any issues of behaviour is to think of a person's physical health. So what we know is as people get older, and the vast majority of people with dementia are older adults, although there are people with younger adults with the condition. But as we get older, there's a number of conditions that we experience that can cause pain. Older adults can become prone to infection, delirium, dehydration is an issue, constipation, incontinence. People tend to be on a number of different medications. There's also sensory impairment. They may not have their reading glasses. They may not have their hearing aids. The temperature may not be appropriate in the environment. They may be hungry or thirsty, and they may have long-term health conditions. And all of these things can impact on how we feel. So, for example, if I have a headache, then I'm probably going to be a bit grumpier, and I'm not going to engage with my family and colleagues in the same way as if I didn't have a headache. But the difference between me and a person with dementia is that I might be able to tell you I've got a headache. I might be able to go and independently get pain relief, whereas a person with dementia may not be able to tell us they're in pain, and they may not be able to ask for pain relief. So all of these physical health conditions can impact on how the person feels, and depending on how they feel, that can impact on how they behave. So it's very important for us to consider whether or not there are physical health factors that need to be addressed before we consider a person's behaviour. And that's before we consider the negative impact that COVID-19 can have on how someone feels and how they behave. So if we've addressed kind of physical health factors, then we need to look at some of the other things that might be impacting on behaviour. So for example, at the moment, isolation is a big issue. So we've already said that that we find social distancing difficult. We find it difficult that we can't see our family and friends. But the person with dementia then is going to have that same difficulty, but they won't understand necessarily that need for social distance. So what we're going to have to do is explain to them why they may need to stay in their rooms, why they may need to stay a distance from other residents in the care home or other inpatients in an inpatient setting. And we need to do this multiple times, because if we tell the person once, they're not going to remember. Because of the dementia, they're going to be more forgetful. So we're going to have to remind them why these measures are in place. And we're going to have to find ways of explaining that to them that meets their needs based on what their understanding is of the situation and what their language and communication skills are. Of course, they're going to be missing their family and friends and staff. And again, as I've said, the difference between them missing their family and friends and staff is that they won't understand why these people have just disappeared and stopped visiting. So we're going to have to remind them about why family aren't visiting. And we're also going to have to use technology and enable them to speak to their family on the phone or through video calls or family sending video messages, etc. Or letters from family, cards for family. The person's also potentially likely to be very lonely. If we think about ourselves socially isolating, then at times we may feel lonely, and the person with dementia is going to feel exactly the same. There's also the possibility that the person could be bored. If I'm sitting at home all day with nothing to occupy me, I'm going to get bored. And if I get bored, I'm going to get up from my seat and I'm going to move around and find something to do. And a person with dementia is no different from me. So unless we have got appropriate occupation, then we're going to become bored and we're going to look and seek appropriate occupation. The other major factor, I think, that is also going to impact on people with dementia at this stage is personal protective equipment. So, for example, in a care setting, should that be in a care home or in an inpatient setting, the residents won't be used to the masks that staff are using. They won't be used to the goggles or the visors, and that can feel like a very frightening experience. So if I'm going about my business and I look around and all of a sudden people around me are wearing all this equipment, I'm going to really worry about why they're wearing that equipment. I might not even know who these people are, because if I can't recognise the care staff, I'm thinking, who is this person with a mask who's coming towards me and coming into my room? That could be really frightening. And how do I know what they're going to do to me? So care staff are going in with protective equipment to support the person with personal care. But does that resident, does that inpatient know that that's what the staff are there to do? Or also, are they worried that something's wrong? Why are all these people wearing this protective clothing? Is there something really serious here? Am I infected? Am I dangerous? Or they might even think, have I been abducted by aliens and am I being experimented on? We have no idea what the person might think of this very alien environment that they're now in, where everyone's wearing this protective equipment. People aren't wanting to touch them as much. It must feel like a very frightening and scary place to be at the moment for a person with dementia. It's a frightening and scary experience for us, and we can understand what's going on. So if we can't understand what's going on, that must make it much worse again. So how can we help in this? We've made some suggestions. So for example, pinning a photograph of yourself to your apron whenever you go in to offer personal care, pin a name to your apron so that the person can clearly see your name, show the person a smiley face so that they recognise this is something that's not going to be unpleasant. Also smile with your eyes. Our emotions, people can see our emotions through our eyes. So if we're portraying emotion of fear and anxiety, the person's going to pick up that fear and anxiety. But if we're engaging our empathy skills and we're smiling at the person, it can help them to feel safer if we're smiling with our eyes. So these are the things that we can do to try and reduce that anxiety. when we're wearing this equipment. Communication. Communication is essential. What we need to do is we need to tell a person who we are, and we need to do that every single time we go into the person's room and every single time we see them, because they may not know who we are. So, hello Jane, I'm Claire, I'm your nurse. We need to use short, simple sentences. We need to give the person time to understand what we've said and respond to what we've said, and then we need to listen to what they say. For people who no longer can understand language or can't communicate, we need to think about using pictures or printed words to help, to help them understand what we've said and to help them to communicate. The other thing that it's important to do is to give positive instructions. Rather than saying, don't go there, don't do that, you can't do this, it's, shall I help you do this? Shall I walk with you? Shall I support you to the toilet? So we're inviting people to do something rather than telling them what not to do. We also don't want to argue, because what we know is that people's reasoning skills are compromised. So by arguing with them, it's really going to just add to their confusion and add to their frustration. So if someone says, I want to go home, saying you can't go home is not going to be helpful. What you want to do is engage with them where they are. Are you missing home? What is it you're missing about home? And then you want to try to redirect them to an activity or to looking at photographs of their family and friends. Because when a person asks to go home, they're not looking for a building. Home is not a building. Home is a place where we feel safe and secure, that's surrounded by the people that we love and who care for us and the things that make us feel comfortable. So when someone's looking to go home, they're not looking for a building, they're looking for that sense of safety and security. And we need to think about how we can offer that safety and security for that particular person. So one of the most important things that we can do during COVID-19, or in fact during any time for a person with dementia, is to try to ensure that they've got access to meaningful occupation. How we spend our day affects how we feel and how we behave. If we spend our day doing things that we enjoy and being occupied with things that give us a sense of achievement, we're going to have a good day. If we spend our day doing very little and doing things that we find difficult and that we aren't able to do effectively, it's going to have a negative impact on our mood. So what we want to do is we want to provide people with dementia with activity and with some structure that gives them a purpose. So there needs to be a reason for me to get up in the morning. For me, it's because of my job and my children, my family, but for the person with dementia, what gives them structure and meaning to their day? And how can we support them to have a day that's helpful and engaging and gives them a sense of purpose? So what we want to do is we want to offer a predictable routine with a variety of activity to help to provide that sense of safety and security. And variety's key here, because no one wants to engage in the same thing for long periods of time. So we want to offer a range of activities throughout the day that the person can engage in. And also we want, as I mentioned, to keep the person to stay connected to their family, their friends, using phone calls or video calls. Encourage the family to write letters, to send cards, to record messages that can be shown to the person at intervals throughout the day whenever they're asking for family. And I'm not going to be able to provide a list of examples, but there's lots of things that people could access, even if they're self-isolating in their room. Singing and music are probably one of the most powerful things that we can do to elevate people's mood. Music evokes really powerful memories for people of happy times. For others, it's for sad times, but it's a very powerful tool. Reminiscing with photographs, with objects, using crafts, setting up a gardening station in someone's room with a small table and a plant pot. Creating a rummage box for someone to look through some things in the box and engage their attention. Getting someone to do household chores, and that may well be, if someone's isolated in the room, it could be sweeping their floor, it could be taking all the clothing out of a drawer and sorting them out and putting them back in again. It can be anything that engages the person in purposeful activity. Photographs, pictures, books and magazines are also really helpful, but the list here can be endless. So one of the things I think that's probably key during COVID-19 for people with dementia and for all of us is that kind of anxiety about kind of what's happening. There's been a change in our lives, there's a change in our situation. And whenever we feel really anxious, we seek safety. And for some of us and for people with dementia, the coping mechanisms they had and the seeking safety behaviours they had before may be no longer available to them because of just the changes with social distancing and isolation with COVID-19 and the access to families. So if we are anxious, what do? We usually call for help. We may shout out. We might ask to go home. We might look for our relatives. We might want to be close to other people. Lots of other behaviours that can be signs of anxiety, the signs I just don't feel safe where I am at the moment. And this anxiety then can present in a variety of different behaviours. And as I say, the person with dementia is no different than any of the rest of us. So if we look at some examples, so if you imagine this is a lady with dementia and she's sitting in her room and she's on her own and she's thinking, where is everyone? She may hear sounds in the corridor and she may be frightened. So she may press her call button. Now, what we need to think about is this may have happened several times earlier that day. So if someone's self-isolating, she may have rang her bell and called for staff several times earlier in that day. So a member of care staff comes in, and this member of care staff may have gone in to see this lady 10, 15 times already that day. And she says, I need the toilet. And he's saying, well, you've just been to the toilet. And he's starting to get frustrated. And he's getting frustrated because there's probably 20 other residents on the floor that he has to look after, and he knows that he's just taken this lady to the toilet 5 minutes ago. But this lady isn't necessarily just looking for the toilet. She's looking for some company. She's anxious, and the way for her to get some company at the moment may be asking to go to the toilet. So the response, telling her that she's been to the toilet 5 minutes ago or recently, or even taking her to the toilet and leaving her again, isn't meeting that need, because her need is for company and her need is for some kind of reassurance. So an unhelpful response is to remind her that she's been to the toilet recently, whereas a helpful response might be to support her to go to the toilet because she may need the toilet, but then after you've supported her to the toilet is to offer an activity. So for this particular lady, it was offering her some flowers to do flower arrangement because that was one of the things that she was interested in. For somebody else, it may be a different activity. But what this is then, it's meeting her need for occupation. And staff can then offer residents or inpatients an activity and then check in on them a little while later to see how they're doing and offer them a different activity. So other behaviours that people may engage in whenever they have an unmet need is they may be asking for relatives. They may be asking to go home. And they may be attempting to leave the building unaccompanied. And all of these things are suggesting that that person has a need that needs to be met. And we need to think about what that need might be and how we can best support that need within the need for social distancing and all of the other infection control issues associated with COVID-19. So if we think, for example, someone sitting in a lounge, this could be in a care home, it could be in an inpatient setting. And we have a lady here and she's asking, where's Susan? And what she's thinking is, in this case, Susan's her daughter, and she's looking for her, and she wants her daughter to come and pick her up and take her home because she's no idea where she is and why she's there. We have another care assistant here who's also very busy. He's other residents to look after. There's other residents who need to be supported to the toilet, may need to be supported to eat, to go to the dining room, etc. So what he's saying is, she's at work, Mary, she'll be in later. And that's an appropriate response for someone who's busy. He's answering her question and he's given her he's telling her that her daughter will be in later. But what does later mean to a person with dementia? Time sometimes can be disrupted. So later could mean a long, long time away. 5 minutes can feel like a long time. What does later mean? Whenever I'm sitting here and I'm feeling really scared and I'm missing my daughter and I don't know what's going on around me. And this is going to be particularly difficult at the minute because the care assistants are going to be wearing protective equipment and the person may feel sort of quite anxious about that. So an unhelpful response is to simply tell her that her daughter is going to be in later because that's not going to stop her missing her daughter and worrying about her daughter. A more helpful response might be for a member of staff to sit down with her a minute, ask her, are you missing Susan? Because that's clearly what's happening. Engage in some conversation about the daughter, and then while the other care assistant then supports the rest of the staff. So what we're doing now is we're meeting this person's needs for a bit of company and to talk and engage with her daughter. And in this example, the care assistant has brought out a photo album, and then she can leave that lady looking at the photo album and reminiscing about her daughter, thinking about her and thinking about some of the happy memories and maybe engage in that for a period of time, and then the staff can go back and support her to do something else. So what we're really thinking about is when someone is asking us for something, when they're looking for relatives, when they're asking to go home, when they're starting to walk and pace the corridors, what is the need that they have, and how can we support them to meet those needs? One of the most common things that people will do within care home settings and within inpatient settings is to look for occupation. So as I just said at the beginning of the talk, if I'm sitting in my living room in the evening and I'm thinking I'm kind of tired sitting in this chair, I need to get up and do something, I'll get up with my chair and I might go and wash my dishes, I may go and do a bit of tidying, but I might look for something to do, or I might call a friend or do something. So a person in a care home is likely to do the same, or in an inpatient setting. They will, if they're sitting in a seat for a long period of time, or they've been in their bedroom for a long period of time, they're going to get up and look for something to do. So they'll start to walk the corridors. And when someone walks the corridors, they're going to go into somebody else's room. So I may have been someone who was a domestic member of staff, for example, before I developed dementia, and I may have been a housekeeper, or I may have been a nurse. And I might find I walk the corridor, I walk into a room and I see someone who needs my help. So I go in, and this lady may have gone into someone else's bedroom and started to care for this lady in bed. But of course, this lady in bed has no idea what's going on, and some stranger has just come into her room and she's frightened. So she's likely to start shouting. The staff are going to come in, and what they're going to tell her is that you can't be here, you need to get out. But what she's going to be thinking is, well, why are they telling me to get out? I'm just doing my job here. I'm in here looking after this lady, or I'm in here to clear this room. So what we've got is we've got three people who each have a very different perspective of what's going on. And what that's going to lead to is going to lead to a lot of distress. And it's going to lead to this lady's going to become, so the lady in the bed is already upset. The lady who's walked into her room is upset because she's thinking that someone's stopping doing her job, and the care assistant is thinking, here we go again, she's wandering the corridors and there's this risk of infection. This situation is probably not going to end well if that's the way that the situation's handled. So what the care member of staff needs to do at this stage is to invite the lady to come and help him with something else. So rather than saying you shouldn't be in here, he's going to need to say is, hello Mary, can you come and help me do something else? So what we really need to do is when we see people starting to walk the corridor, starting to get up to look for occupation, we need to invite them to come and engage in occupation. So at the stage before this lady got into that room to upset someone else, it would have been, hello Penny, can you come and help me with the laundry? So we're not telling her that she can't go there, but we're inviting her to engage with us in occupation, and we're going to give her some meaningful activity. So that's the way that we best support somebody in terms of redirecting them, but redirecting in a very positive way and giving them something to do. Because this lady would be labelled as interfering with others, but that wasn't her intention to interfere with others. Her intention was to go in to clean that room or to go in and care for that other resident. She saw herself as a younger person who had a job to do, and she was doing her job. If we move on to things like personal care is probably one of the most challenging experiences that care staff report whenever they're supporting a person with dementia. But if we think about ourselves, if we think about someone coming in to support us with personal care, it's not a very good experience. None of us wants to expose our bodies to other people. So actually, even the experience of being supported with personal care is a very, very difficult experience for any of us. But that would be difficult for us, and we know what's happening. But if you're a person with dementia and some stranger comes into your room to support you with personal care, that can be a terrifying experience. So what this can lead to is it can lead to misunderstanding and fear. So if some stranger walks into my room when I'm lying in bed and I'm frightened and I don't know who they are, I'm likely to defend myself. So I may shout out, I may put my hands up to defend myself, or if they try to touch me, I may try and resist them touching. So my misunderstanding of who they are and my fear of who they are would then be interpreted by the carer as verbal or physical aggression. So if we can see here, this lady's lying in bed. The care assistant's gone in to try and support her with personal care. So she's removing the duvet so that she can help and support her to get up. But the lady doesn't understand what's going on. So all she sees is I'm lying in bed here and this woman's come in and she's starting to take my duvet off. Why is she doing this? And also, if we think about it, first thing in the morning, when we're kind of lying cozied up on our duvet and we're nice and warm, if someone removes that duvet, we're going to feel cold. So this lady is frightened. She doesn't know what's going on and she's feeling cold. So what we need to do is, as carers and staff, is that we need to find a way of helping this lady to understand who we are and what we're doing before we try to support with personal care. So a more helpful response might be to sit down briefly with the lady. Say hello. Hello, Barbara. I'm Lisa, a care assistant. How are you today? Then we can give Barbara time to process this. Okay, this person seems quite friendly. This is not a rushed experience, and give the lady time to work out who you are. You might have to provide a bit more information about who you are, but this can help her to start to feel relaxed. If we do this, then what we're more likely to do is the person's more likely to be cooperative in terms of our support with personal care, and we can invite them to engage as independently as possible. And we can use visual cues as well. We can have a towel, we can have a piece of soap, all of these things that provide visual cues that we're here to support with personal care. The other thing I think that we need to be very mindful of personal care is that people's experience of pain. Older adults tend to be more prone to things like arthritis or just general aches and pains that they have as they get older. And we know at night, as well as when we've been sleeping all night, when we wake up first thing in the morning, we could be kind of quite stiff from lying in bed. And if we don't pay attention to this and are mindful of this, we can actually cause that person more pain as we support them to move. So what we know is ourselves, if we experience pain, we'll shout out or we may lift our hand up. So if I have a sore leg and somebody accidentally touches my leg, I might shout out, I might ask them to stop, or I might move my hand very quickly to move them out of the way. And the same will be true of a person with dementia. So in this picture here, we have a lady. There's two members of staff supporting her to get out of bed. She's feeling a lot of pain, but they don't understand that she's in pain. So she's telling them to stop. She's telling them to stop because they're hurting her, but they don't understand that they're hurting her. They're not trying to hurt her on purpose. They're trying to do their jobs. But they don't know what's wrong because the pain's invisible. It's not like she's got a plaster of Paris with a broken arm, that they can't see the pain, so they don't understand that the pain's there. So what's happened is that through lack of knowledge that she's experiencing pain, they're getting her up in the morning and they're hurting her more. So what will happen here is she's probably going to either start shouting louder, or she's going to stop them from moving her, and they're going to interpret that as aggression. And she'll be labelled as being physically or verbally aggressive. But if we understand that she's experiencing pain, then what we can then do in the morning is we can go in 15, 20, 30 minutes earlier. We can offer pain relief. We can give the pain relief time to kick in, tell the person we'll be back in half an hour, and then we can come back and we can offer support when the person's less likely to be in pain. So all of these small steps that we can take by understanding the perspective of the person who can't tell us what they're feeling all of the time. If we can anticipate how they might be feeling, then we can reduce some of the distress that they might experience. I'm not going to go into any much more detail about sleep because I know I want to leave some time for questions, but I just want to speak very briefly about sleep. What can happen sometimes is that people can nap during the day. And if people are napping during the day, either sitting on the lounge or in their bedrooms, they're not going to sleep well at night. So they're going to have disturbed sleep at night. So if we allow our residents in care homes or our inpatients in the inpatient unit to sleep for extended periods during the day, then they're going to be up at night. What we need to do is engage people in meaningful activity throughout the day where they're occupied. If they're occupied and busy during the day, then they're more likely to have better sleep at night. Okay, So just finally then, just before we kind of move to questions. So the one thing that I like to say is that before you respond to any behaviour of a person with dementia or with anyone, is think about perspective. We can get it wrong with ourselves and our colleagues, our friends, and we can absolutely get it wrong with people with dementia. Is the first thing we need to ask is, does the person understand what is happening? And if we think they don't understand, what can we do to help them to understand? That's to understand who we are or to understand what we're doing. And I think the thing that we need to remember is that behaviour is not random and behaviour is not as complex as we think. Most of our behaviour is fairly routine and we behave in ways to meet our needs. Look for patterns in behaviour. Clear Dementia Care have a series of kind of recording tools that we look for, behaviour record charts that look for patterns when people behave in certain ways to help us to better understand behaviour. But what we really need to remember is that in the context of COVID-19 is that there's a very vulnerable person trying to meet their needs in a new and very confusing environment. And we really need to try and find ways to offer them support to help them to meet these needs. If you want a bit more information, that with my colleague Jill Richardson, an associate psychologist, we've written a brief paper that covers some of the things that I've talked about here. Our Trust website, you can download the paper from the Trust website, and also there's a bit more information on Clear Dementia Care. What we'll be releasing probably in the next few weeks is that we've got a good working version of our Clear Dementia Care app. This will be an app that will be free to download for both from both iTunes and Google Play. And what it is it talks about Clear Dementia Care. It talks about behaviours, and there's the ability to record and look for patterns in behaviour within the app. So we'll be releasing this, on social media whenever it's out, but it should be available in the next, kind of month or so. There's a few references, obviously, if people are kind of interested in our work and what we've been doing. And I think the other thing is that we have a book, Clear Dementia Care, that talks about the principles of Clear Dementia Care. So if anybody's got any questions, we'll probably take them in a second, but you can email me or you can check out our website. And again, there's the kind of Twitter handle as well. So I think, Fatima, I will hand back to you, if that's okay.
Brilliant. Thank you, Frances. Okay, so I could hear a bit of a lag. Frances, would you mind just turning off your... that's fine. So we'll start off with some of the popular questions. And the first one is, so what about people with dementia who are unable to engage in activities by themselves and require constant support for this?
Yeah, I think that for people who are perhaps either very unwell or people who are maybe in the later stages of dementia who are not able to engage in activities, music's very powerful for a lot of people. So people can usually still hear music. We can sing with a person. We can also think about whether or not there's any kind of other tactile. So is there any other kind of sensory objects that we can have the person to actually just to hold, to have some kind of sensory experience? And part of that is really, I suppose, thinking about being just quite creative in terms of, is there any way in which we can engage the person's senses? And part of that might just be checking in with the person. It's unlikely that someone needs constant attention if they're feeling happy and secure. So someone who we feel needs constant attention is clearly not feeling very secure in terms of where they are. So we need to think about the environment that they're in and how can we make that environment feel a much safer and more secure place. Some of that might even be playing recordings of family so that they can hear familiar voices. And again, checking in on that person kind of regularly. So I think it is about maybe going in, playing some music, spend a little bit of time talking, playing some music, leaving the person with the music, coming back again and checking in.
Okay, so the next question is, just wondered in terms of technology, how many colleagues have people they work with who have access to or can work technology? And in their service, they're finding it very few people I guess, know how to work around. How do you work around this? I guess it's regarding, I guess, staff being able to, I guess, use technology.
Sorry, I'm not sure about that question. Could you say that again?
So just wondered, in terms of technology, how many colleagues have people they work with who have access or can work technology? And they're saying in their service, we're finding it very few do. And how do we work around this? Okay,
so by technology then, I'm assuming that they're talking about phone calls or video calls. Because there's lots of activity, most of the activities that people with dementia engage in don't use technology. So there's lots of things that we can engage in with a person with dementia that doesn't require technology. So many activities like listening to music doesn't require technology. Arts and crafts activities don't require technology. So I suppose if technology is available, it's great, but there are lots of things that people can do without access to technology. And most people have access to mobile phones. Even if it's not a smartphone, there's usually a phone that people can access where they can have even a voice call with somebody.
Okay, so this is an interesting question. Do colleagues feel it's helpful or unhelpful for family members to visit and wave through a window?
Yeah, I think that's a really good question. And I think there's no one answer to that, because for some people, that standing at the window and waving at the person gives that person a lot of comfort that they can see you. So I think when that's happening and the person's not distressed, I think it's a really good thing to do. The other difficulty is that sometimes for some people it may cause distress because they can't understand why the person, isn't coming in. So I think with that, then it may be that if that's the case where the person's distressed and the person's outside the window, it may be that a member of staff should be in the room with the person, explaining to them that their son, their daughter, their husband, their wife is outside the window, explaining that there's an infection present at the moment and that's why they can't come in. So I think that there would probably be very few circumstances when that wasn't a good thing to do, because I think the fact that if the person is missing their family, I think just seeing their family, even if it's through a screen, is probably really helpful.
Okay. Oh, I've got a fair few questions coming up now. Do you have any recommendations for helping deliver these messages to care staff when we have limited access to the homes? I have found this important message about reasons for behaviours can be lost when consulting by phone, and the suggested solutions may require more time investment when staff time is already stretched. Yeah,
again, that's a really important question. So we work in a specialist service that would have gone into care homes regularly and offered support to care staff. So we would have been able to see care staff one-to-one, and we would have been able to spend time with the person. With COVID-19, that's just not possible now because of the risk of infection. So what we've done is we've developed a kind of telephone consultation service. But again, that's not ideal because your staff don't have time to engage in lengthy assessments. What you'll see is that if you go to the website, you'll see that I updated the document that was released a few weeks ago. And what we've done is we've created a series of posters. So I think there's about 20 posters in the appendix of the document, and we're sending these out to our care homes, and we're asking the staff just to laminate them and put them on the wall. So we have like just a very brief document, for example, is when the person walks, when the person asks to go home, when the person's looking for family, when the person's asking, repeated questions. And if staff have these available and they're laminated somewhere, then it means that it's it's a readily available resource that they can use. Because in this time, we know that staff are really busy. We know they're under an awful lot of pressure. They don't have a lot of time to engage with outside services, and they need something which is kind of fairly straightforward and easy to kind of think about. So each of these posters, they just have some tips whenever a person's engaged in a particular behaviour. So the staff might find those helpful, to send those out. If you can download them from the website, and they might find those helpful to kind of just print out and get staff to laminate those.
Okay. So another popular question, following the updated guidelines for visiting in hospitals to support patients with dementia, how many of your patients been supported by their families and how?
How many are being supported?
how many of your patients have been supported by the families and how?
So how many of mine is that, or?
I think it's directed to you.
Right, okay. So I'm aware that I mean, I couldn't tell you, how many, but I am aware that that in care homes that we're working into, that particularly for the people who are at the end of their life at the moment, that there are a number of families who've gone in and spent time, with the person. So we are if families want to do that, we are permitting families to go in to visit in care homes and in hospitals, but I couldn't tell you how many are doing that, but we're facilitating that, and it's been very successful. There's been very positive feedback from the staff and from the families about having that experience.
Okay. We'll get a couple more questions. So, what are the best ways to keep families and carers informed about how a person is? Yeah,
I think that's a real challenge. So, I mean, I can just tell you about the experience of our trust. So what we were finding is that our care homes and even the inpatient settings are extremely busy at the moment. So because a lot of the residents would be unwell, and even in the inpatients, if they have COVID-19, they're very unwell. So staff's time is really taken up with physical care needs a lot more than it would have been before. And that's the case now even in kind of residential homes where there would have been less nursing care before. So what we're offering is we've offered a family liaison service. So we will have 1 or 2 members of our team that will be attached to a care home, and they will be answering the phones to family, and they will be phoning. So we've given the families their mobile numbers, and that member of staff then, the family can phone that member of staff and allocated time. That person will be in their loved one's room, and they will be able to give them feedback live feedback in terms of how they are. So if the person is able to speak to their family, they'll be able to speak to them. But if the person is unwell or has communication difficulties, then the member of staff can tell the family exactly how the person is and what they're doing. The care home staff have in particular reported to us that that's been invaluable, because it means that they can go on with the business of caring, and there's other staff coming in that can then negotiate and talk to families, and families have found that really extremely valuable, because what was happening before was that the care home lines were just kind of ringing out because the staff didn't have time to answer the phones, and that was increasing anxiety of families. So that family liaison service has been really invaluable.
Okay. So another question is, any advice on patients being suspicious about taking medication and how to support compliance?
Yes, again, we have on one of the posters that I mentioned to you, we've got one of those, because and I think this is going to be even more so during COVID, when staff are wearing kind of all of the uniforms and the masks, and they're offering medication to residents. The residents or the inpatient may not realise what this medication is for, and part of that is the way that the medication is offered. So, for example, it might be that when sometimes we'll offer medication when someone's eating, but that might not be the best time to offer the medication. It might be after they've eaten. And what we're doing with people is we're actually explaining what the medication is for. So we're saying, okay, this tablet is for your blood pressure. The doctor has given you this for your blood pressure, so we're explaining what it's for. If the person declines, then what we're doing is we'll wait and we'll come back and we'll offer it at a period later. But the timing for the medication is really important in terms of making sure the person's not distracted with something else, and they're not hungry. But also the way that the medication is offered. So for some people, they like to hold out your hand and you give it to them in their hand and they take it. For other people, they prefer you to give them the medication in their mouth. So we find out, how does that person like to accept their medication? What's the best time to offer the person their medication? And what's the best thing to say? Because, or it might be, you could say, if it's for pain, for example, this tablet will help with the pain in your leg. And if people understand that, then that might help. And also for people who don't understand language, then we may show them photographs of that.
Okay, so just one more question, just conscious of time, and this is quite interesting. So in Germany, we've seen robot initiatives being used in care homes. Would this be safe to use with people with dementia?
That's a really good question, and I don't know the answer. I think it would really depend on the person, because for some people with dementia, they may respond to a robot and really kind of like that experience. For others, they could find it kind of quite frightening and confusing. So I think it would be, first of all, it would be how that robot was introduced. So it would be, if it's introduced obviously with a person, and then the person with dementia gets used to that, then they might be very comfortable with it. It might just be part of their routine. For other people, it just may never work, and the person may never, you know, kind of get to grips with that kind of technology. So I think there's probably no one answer fits all, but I think if it's available, it's a very good idea to try it, but it would need to be tried in the right way in terms of making sure that that person wasn't frightened and making sure they were supported appropriately with the introduction.
Brilliant. Thank you so much, Frances. I'm afraid that's all we've got time for. And I'm conscious that we do have a couple more questions, but we'll share these with Frances. And of course, if you want to take those questions forward and later explore them, they can do that. So before we finish off, just want to give you just very brief information about some of the other sessions that we've got coming up. So just bear with me while I plop my screen. Okay, so just to finish up, just to remind you that we do have some of upcoming events coming up. So we have a special interest events week that's going to be starting from the 6th of July. And we are exploring a series of webinars exploring complexities of diagnosing in older adult mental health service. We are looking for speakers to present, as well as it's open to our members to begin signing up to these events. We're also putting on some reflective space. So these are informal settings to connect with peers and to, I guess, just reflect on what's currently happening and how to, I guess, informally support each other in this difficult time. These are only available to members at this stage, but you know, our memberships, you can, if you want to make inquiries about membership, you can do, and we can support you in deciding on, I guess, what level of membership that you would like to join at. There's also useful resources on the Royal College of Psychiatrists website. We are working with NHS England and improvements to create up-to-date guidance and guidelines for psychiatrists as well as other healthcare professionals. So do visit our website to find out more. We also have a COVID-19 discussion group on our Knowledge Hub. And if you remember, and if you would like, information on how to access it, please do get in touch. And it's regularly updated, and it's just a way of supporting you through this difficult time. Thank you so much, and thank you so much, Frances. A fantastic talk, and no doubt that we'll have more requests to do something quite similar. So thank you for coming, and we hope to welcome you again. Take care.
Thanks.